Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hi everyone, I am Sandeep. I am a clinical fellow at Great Ormond Street Hospital and I will be talking about pediatric brain tumors today. So this is basically an imaging update on the recent classification 2021 WHO classification of pediatric brain tumors. And as we can see, the pediatric brain tumors are the most common solid neoplasms which are seen in children. And the latest classification, as I mentioned, is a WHO 2021 classification. It's very important that we remember that children are not small adults, and what we use, the terminology such as glioblastoma in adults are not really applicable in children. And also, the pattern of post-contrast enhancement and diffusion restriction are not really the same as in adults. So we can have highly restricting tumors but without any post-contrast enhancement. So those can be high grade in children. That may not be the case in adults. So moving on to the imaging techniques, we have both CT and MRI available to us. CT is usually used as an initial screening tool without any sedation, and it just gives us a basic outline about the mass and whether there is any hydrocephalus. And we don't give usually any contrast for the initial CT screening because it's taken as a modality which is done for the immediate time frame. And the MRI is the definitive modality of choice. We can do it either in 1.5 or 3 Tesla. And we have to remember that the RAPNO guidelines is what is used to classify these tumors and also to measure them. We have advanced imaging modalities such as diffusion tensor imaging, MR spectroscopy, and MR perfusion, though they're not routinely used, and only if there exists a diagnostic confusion between low and high grade tumors, that is when we tend to use them. Moving on to the postoperative surveillance of these tumors. Remember that tumors after resection, we can have an intraoperative MRI during the resection or immediately another scan immediately following the resection within the first 72 hours of the surgery, preferably in the first 24 hours. Remember, always look at the margins of the tumor, and if it is hyperintense in T1, make sure that we have a pre-contrast T1 because most of the time it is blood postoperative hemorrhage which is surrounding the margins of the cavity and not real post-contrast enhancement. So diffusion and pre-contrast T1 is very critical to exclude just hemorrhage surrounding the postoperative cavity, and it is very less likely that we are going to see post-contrast enhancement there. Radiation necrosis is usually something which happens down the line, so it's not an immediate postoperative complication, and usually we see it a few months down the line. And progression versus pseudo progression is another critical problem we face as radiologists. This is something which was taken from an article just to demonstrate that this was a medulloblastoma in the posterior fossa, and we can see that over time they can go on to develop a posterior fossa syndrome. The child can become mute. It's called cerebral mutism. And remember that there can be a biomarker for the same, which is basically olivary degeneration involving the anterolateral aspect of the medulla, which can be a subtle biomarker for the same. Just showing you the broad WHO 2021 classification, we can see that there are multiple tumor types here. We have gliomas, we have glioneuronal tumors, we have choroplexus tumors, embryonal tumors, cranial spinal tumors, meningiomas, melanocytic tumors, and finally metastasis to the CNS. So we don't really have a pediatric specific classification here, and it is usually the adult and the pediatric combined. And as you can see, there are multiple groups here. We will not be going through all of them, but only a few of them, and the most important ones among those. Another picture is taken from an article just to demonstrate that we are, even though we have the traditional diagnosis of most of the tumors, most of them are being targeted molecularly, and we can see that the BRAF point mutation is one of the most common things we encounter now. And in the case of PXAs, pleomorphic xanthoastrocytomas, and pilocytic astrocytomas, it is quite common to have this mutation, and we have specific therapy inhibitors for the same, and that can be targeted as well. So moving on to our first case, so we'll do this talk on a case-by-case basis. We can see that here we have a posterior fossa mass which is in the midline. In T2 we can see that it's quite intermediate on T2 and it is restricting. This is the diffusion restriction images, and on the ADC we have a significant fall in the ADC values, and in post-contrast we can see that there is a heterogeneous post-contrast enhancement of the lesion. There is no blooming in SWI. Again, we can see that the mass is quite midline, and in a child, when you have a midline posterior fossa mass, which is arising from the fourth ventricle and which is showing diffusion restriction and post-contrast enhancement, the differential would be medulloblastoma. So remember, embryonal tumors can be medulloblastomas, it can be ATRTs, or even supratentorially they can occur, and they are WHO grade 4 tumors and they are high malignant and cellular. Among the posterior fossa tumors, remember medulloblastoma has an average age of presentation around 9 years. They're WHO grade 4, as I mentioned before, highly cellular. And in MRS, we can identify a taurine peak sometimes. Sometimes they can calcify, quite rare though, around 10%. Cyst and necrosis are still more common. You can have it 50% of the cases. The most recent classification for medulloblastomas is the molecular classification, where we divide them into the Wnt group, the SHH group, and finally the non-Wnt or non-SHH group. So among these, the Wnt has the best prognosis. It can be off midline in the cerebellopontine angle, or it can be in the midline location. Intratumoral hemorrhage and necrosis are more common there. SHH group can be again divided into the TP53 wild and the mutant type. And remember, they occur laterally in the cerebellar hemispheres. They are associated with histologically a desmoplastic morphology. And among the non-Wnt, non-SHH groups, W group 3 and group 4, they are the most common tumors we encounter. And the one we saw previously was again a group 3 medulloblastoma. They tend to occur in the midline. And group 4 are the ones which are hypo-enhancing out of all these. So moving on to another embryonal tumor. This is a 2-month-old girl. Always look at the age of presentation of these pediatric brain neoplasms. So this was a 2-month-old girl with signs of raised intracranial pressure. What we see here is a very heterogeneous mass in the posterior fossa. As you can see, it is slightly off midline towards the left side, and it is showing diffusion restriction, at least a solid component. So we can see that the mass is both cystic as well as solid, and the solid component of the mass is showing intense post-contrast enhancement, and even the margins of the cyst is showing post-contrast enhancement. So in a 2-month-old girl, remember the age is quite critical here. Any child less than 1 year, we would think of ATRT in the posterior fossa, and this also turned out to be the same. Remember, they can be both supra or infratentorial. It can be intra or extraxial. Sometimes on MRI, we have on the post-contrast images an enhancing wavy band has been described with central hypointensities. They tend to restrict and they are quite heterogeneous. They tend to be lateral as well. And remember, the cyst, they are quite, as the heterogeneity goes, they can be cystic, they can be associated with calcifications and intratumoral hemorrhage. Whereas medulloblastomas, on the other hand, are much more homogeneous. That is one way to differentiate between the two. Molecularly, ATRTs can be of the TYR type, SHH, the MYC, or the SMARC4A types, and some of them, out of at least 2 of them, are more in the supratentorial region than in the posterior fossa. It's not really important to differentiate between the two. As long as we say ATRT, I think that should be okay. But the difference basically is that the TYR type is more in the posterior fossa, and the others are equally distributed between the same, and some of them have a slightly lesser degree of enhancement, like for example the SHH. Moving on to the supratentorial embryonal tumors, they can be of 4 different types. It can be not otherwise specified. It can be an ETMR, it can be a FOXR2 activated neuroblastoma, and finally a supratentorial ATRT as well. Typically, they are quite large at the time of presentation. Around 6 centimeters is the median size. They tend to be both solid as well as cystic, and they can have a intense post-contrast enhancement. Again, hemorrhagic and calcified lesions are the most common types, and differentials here would be a supratentorial ependymoma and high-grade gliomas. Let's have a look at this particular case. So this was a 5-year-old child who came with occipital headache. We can see that there was a mass involving the right parietal occipital region. It is relatively well defined and quite intermediate signal on T2. And if you see the diffusion restriction, you can see that the periphery of the mass shows some degree of diffusion restriction, though not not like the ones we saw before in medulloblastoma or in ATRT where you have intense restriction, and we can see that the solid portion of the mass is showing post-contrast enhancement. Some minimal perilesional edema is also seen surrounding the mass. So this turned out to be a FOXR2 activated embryonal supratentorial tumor. Just to summarize what we have learned so far, so we have talked about embryonal tumors. We have talked first about medulloblastomas, which is a very cellular tumor. It is usually in the midline. It can even arise on the lateral cerebellar hemispheres, as we saw in the Windpa group. They tend to restrict. That is the most important feature. In ATRTs, remember, they can be both supra and infratentorial. And if they are infratentorial, they tend to be towards one side. They are quite lateral, as well as they are very heterogeneous and restrict as well. In the supratentorial embryonal groups, remember, they tend to restrict and they are very large hemispheric masses with variable amount of cyst and necrosis within the tumor. Let's move on to the next subgroup of pediatric tumors. So we have pediatric gliomas. Among them, we have a diffuse high-grade glioma. We can have a circumscribed glioma. We can have ependymomas, and finally, you have the broad group of neuronal glioneuronal tumors. Let's have a look at them one by one. So this was again a 7-year-old boy who came with complaints of headache and multiple episodes of vomiting. So what we can see here is a diffuse expansion of the pons. As we can see here, there is encasement of the basilar artery, which is again a very characteristic feature of this particular tumor. The mass is quite heterogeneous in T2, and you can see that the margins of the mass, especially the posterior fossa, posterior margins, are not really well defined. There is some extension to the middle cerebellar peduncles, and also there are a few foci blooming within the mass. And in the post-contrast images, we have the pre and the post-contrast side by side. We can see that there are a few areas of enhancement within the mass without any significant diffusion restriction. So in summary, we have an expansile lesion involving the pons and which is encasing the basilar artery. I'm sure most of you would know the diagnosis by now. So this is a typical diffuse midline glioma, and as we call them now, it's called H3K27 altered. And previously it used to be called diffuse intrinsic pontine glioma because it is presumed to arise from the pons. But now, however, most of them have an extrapontine extension. You can see them in the thalamus, you can see them in the medulla, or even in the spine. And most of them are non-enhancing, even though patchy or ring enhancement is seen in approximately 30% of the cases. And remember, if you have necrosis, enhancement within the mass, lower ADCs, or there is lateral extension to the middle cerebellar peduncles, they tend to have a poor prognosis. Let's go on to another subtype of the high-grade glioma. So what we see here is a diffuse expansile mass which is involving the right cerebral hemisphere, predominantly involving the right temporal lobe. Again, we can see that the mass is quite heterogeneous in T2. It has an intermediate signal, pretty relatively well-defined borders, and some degree of perilesional edema. There is some diffusion restriction predominantly along the anterior and lateral aspects of the mass, and the mass is showing large areas of hemorrhage within and some degree of calcifications as well. It's difficult to tell with just the SWI images, and you can see that the mass showing thick ring-like post-contrast enhancement with a large central necrotic area within. Even the margins of the masses tend to be enhancing. So it is something very similar to what we saw before, like the supratentorial embryonal tumor. And when you see the MR spectroscopy, we can see that there is a large lipid lactate peak and some degree of the elevation of choline and some drop in NAA. And if you look at the perfusion images, you can see that the enhancing solid component of the mass is showing an increased area of perfusion. So in a related, this child was relatively old, actually was 10 years old at the time of diagnosis. So in a relatively older child with a large hemispheric mass, and you can see the sort of enhancement which is relatively peripheral, like how you see in the adult gliomas. So this is typical for a pediatric diffuse type of high-grade gliomas, and this was a wild type of tumor. So remember, a non-midline diffuse high-grade glioma can be both H3G34 mutant and the H3 wild type. So they typically tend to occur in a slightly older child, like in an adolescent. Again, we cannot really differentiate based on the characteristics. They tend to be large hemispheric masses. They tend to be heterogeneous. As any large mass would, they would have some degree of hemorrhage and calcifications. The diffusion and enhancement is usually there in the solid component of the mass. Now let's go to a more typical case. This is again a posterior fossa mass now. So this is a 13-year-old boy with swing. we can see there is a heterogeneous mass which is relatively well defined. It is again slightly eccentric, it's off midline and arising from the cerebellar hemisphere, and we can see that it is quite hyperintense in T2. There are some cystic components within the mass, and it is not really showing any diffusion restriction as noted by the lack of fall in ADC, and it is showing this intense post-contrast enhancement. So when you have an intensely enhancing mass in the posterior fossa which is quite bright in T2 and which is not restricting, in a child our differential would be pilocytic astrocytoma, and the same thing in an adult we would think of hemangioblastomas, but this is a 13-year-old boy, and pilocytic astrocytomas is typically how they look like. So remember, in pilocytic astrocytoma, as I showed you in my second slide, we could either have a BRAF fusion or a BRAF V600E point mutation, which are the two most common associations. They are associated with NF1. It's a WHO grade 1 tumor. They are well circumscribed. So an important thing to remember is the cyst plus mural nodule configuration. So this cyst plus mural nodule configuration, if it's in the infratentorial region, pilocytic astrocytoma is the most common tumor to have that particular morphology. And remember, it at times it can be just solid, like a heterogeneously solid tumor. It can also be multicystic with tiny nodular components. So it's not always a must that you need to have the cyst plus mural nodule configuration in the posterior fossa. And robust enhancement is one of the key features of the same. What happens if the pilocytic astrocytoma tends to occur in the supratentorial parenchyma? So if it occurs in the supratentorial parenchyma, it involves the opticopathway hypothalamic region. And remember, that is the most common location, and they tend to be expansile, and they tend to have moderate post-contrast enhancement. Remember, PXAs are another group of supratentorial astrocytomas which tend to have a cyst plus mural nodule configuration, which tend to scallop the inner table of the calvarium. Let's have a look at this opticopathway glioma, which is a very common tumor, and they tend to have blindness of some degree because they tend to involve the optic nerves. As you can see here, there is involvement of the right optic nerve, which is quite expanded, and as you can see, there is a midline mass which is involving the optic chiasm, which is epicentered there, which is quite heterogeneous, and as you can see along the left lateral aspect, there are some cystic components within the mass. There is no diffusion restriction, and the mass is heterogeneously enhancing post-contrast. So it's always important to trace these masses more anteriorly and to see their extension to the optic nerves. As you can see here, there is involvement of the right optic nerve, the retroorbital portion of the optic nerve. Right. Let's move on to the next type, which is the pediatric type diffuse low-grade gliomas. So among the low-grade gliomas, it can be either a diffuse astrocytoma, it can be a diffuse low-grade glioma, the MAPK altered type, it can be an angiocentric glioma, or finally the new entity which is called plenty, a polymorphous low-grade neuroepithelial tumor of the young. So remember, we are not going to see all of them today, just a few, one example, one. Here, this is a 1.5-year-old boy, a 1.5-year-old boy who presented with slowly progressive headache. So it looks quite aggressive, isn't it? That is the first impression we get from this tumor. It is a very large tumor, which is in the hemispheric location in the left side, involving the left parietal region. And remember, if you look at this in T2, it is very, very homogeneous, isn't it? The margins appear relatively well defined. And if you look at the flare and the T2 and you compare both these images, you see that there is an incomplete suppression on the flare. So this is what we see in the adult, in the IDH astrocytomas. So we have the T2 flare mismatch. So that is something which is typically seen in this tumor. And in the post-contrast images, you can see these linear sort of vessel enhancement within the tumor. No solid components are seen, and in the perfusion images it is hypoperfusic and it is not restricting as well. So a large hemispheric mass which is showing T2 flare mismatch and which is quite well circumscribed and without any post-contrast enhancement. This entity is called a or a MIB1 altered glioma. Again, it falls in the subcategory of diffuse astrocytomas. The cerebral hemispheres are more common in location than the diencephalon or the brainstem. As I said before, T2 flare mismatch is one of the typical features for the same, and a homogeneous T2 signal, a low CRPV, and a low ADC value would be in keeping with this tumor. So we have seen about the pediatric high and low grade gliomas. Next, moving on to an ependymoma. So in ependymomas, remember they can be infratentorial, they can be supratentorial or spinal. We're We're going to see examples of each of these. So this is an example of a typical infratentorial ependymoma where we can see there is a solid cystic mass which is actually involving the posterior fossa. You can see that the cystic mass of cystic portion of the mass is extending laterally into the left foramina flushka. This is a very typical feature of this tumor where you have this pliability and extension to the foramina flushka and the foramina majenti. And also what we can see is that in the diffusion restriction images, there are no real restriction of the lesion. Even though it looks a bit bright on the diffusion weighted image, there is no real drop in the ADC map. And you can see that the mass is showing heterogeneous post-contrast enhancement. And if you look carefully, you can see the inferior extension of the mass along the foramen of Magenti. So it has the typical feature of pliability, extension to the foramen of Luschka and Magenti, and no diffusion restriction. So this is very typical for an ependymoma involving the posterior fossa. And remember, ependymomas in the posterior fossa can be either type A or type B, and type A tends to occur in very young children with a poorer prognosis. They tend to go laterally, whereas type B ependymomas are more usual in the older child. They have an excellent prognosis and they tend to go inferiorly into the floor of the opex. Remember, they tend to get calcified as well. 50% of them show some degree of calcifications. What about supratentorial ependymoma? Supratentorial ependymomas tend to have a predilection for the frontal and the parietal lobes, and they have two genes are commonly encountered here. One is a ZFTA or the YAP1 fusion positive. Out of the ZFTA ones are usually the older child and they have a poorer prognosis, whereas a YAP1 is seen in the infant with a very good prognosis. This was a case of ZFTA fusion positive ependymoma in the supratentorial region. You can see again a large hemispheric mass which is solid cystic, and the solid portion of the mass is quite heterogeneous in T2, and in the pre-contrast T1 itself, you can see some degree of hemorrhage along the right lateral aspect of the mass. Central portion of the mass shows some degree of diffusion restriction within it, and there are large areas of calcifications which are seen along the left lateral aspect of the mass. And on the post-contrast images, we can see that the solid portion of the mass is showing intense post-contrast enhancement, and even the cyst, the margins of the cyst is also showing some post-contrast enhancement. So basically, you have a solid cystic mass which is showing intense post-contrast enhancement. So if it is hemorrhagic, calcified, these are the two typical features seen in the supratentorial ependymomas. So if you read an article, there is also a sign described called periwinkle sign, where we have these sort of large centripetal calcifications which are quite typical for supratentorial ependymomas. Moving on to the next group of pediatric tumors, which is the glioneuronal tumors. The two typical examples of the same are DNETs and gangliomas. So this was a very young child who came with complaints of headache again. You can see that there is a large cystic mass in the left frontotemporal region, and we can see on T2 itself it's quite heterogeneous. There are some dark areas within the mass, and it is showing some degree of diffusion restriction here, as you can see in the ADC values. And in the GRE image or in the SWI image, you can see that there is some degree of calcifications as well in the center of the mass. There is a heterogeneous enhancement of the mass as well, predominantly along the lateral aspect. So again, now we have a solid cystic mass or a cystic mass with a mural nodule, as we can say. In the hemisphere, it's basically in the lateral aspect of the hemisphere. It's almost cortical based, you can tell. And a differential for this would be gangliogliomas, PXAs, and even pilocytic astrocytomas to an extent. So as I told you before, this is a very young child, and this turned out to be a case of desmoplastic infantile ganglioglioma, again WHO grade 1, with undifferentiated neuroepithelial components. So gangliogliomas tend to have a very indolent course and an excellent prognosis. They are a typical cause of seizures, long-term seizures in the child, and the temporal lobe is the most common location for the same. They tend to have a cyst plus mural nodule configuration, with calcifications being quite common, and they do not restrict. This is another typical cortical based tumor responsible for refractory seizures. You can see that this is a left posterior parietal mass which is quite lobulated, and it is having a flare hyperintense rim, also called a flare rim sign, and there is no post contrast enhancement within the mass, and there is no calcifications at all in the SWI image. And if you notice on the T2 weighted image, you can see the sort of wedge shaped appearance. So the mass actually tapers towards the lateral ventricle. So this is very typical for a DNET. This is how it presents. You have the flare rim sign, and you have the tapering or the wedge-shaped appearance towards the lateral ventricle and the lobulated appearance of the mass. So this is how it looks like. So many a time the DNETs are associated with an underlying cortical dysplasia which may not be detectable on the MRI, and you need it will be proven histopathologically down the line. They tend to have a bubbly appearance as well, a bright rim sign, as I told you. Typically there is no enhancement, although small nodular or ring-like foci have been described for the same. Right. So now let's move on to the next tumor type, which is a coral plexus tumor. So typically, coral plexus tumors tend to occur in the lateral ventricles, followed by the fourth and then the third ventricle. Remember, the most important word for the coral plexus tumor would be papillary frond-like appearance of the tumor. They tend to be quite lobulated in shape. So the shape of the tumor becomes really important for the characterization of this particular mass. And they tend to cause hydrocephalus as well because they are intrinsically within the ventricle. So let's have a look at this particular case. So if you see here, you have a very heterogeneous but lobulated mass. You can see the frond-like appearance of the mass as well, which is epicentered in the right atrium of lateral ventricle. Many a times when we have such a big mass, it becomes very difficult to differentiate the origin of the mass, whether it's originating from the hemisphere or is originating from the ventricles or from the callosum. But it is so the serial imaging is quite important here, and to see the growth of the tumor as well. Right. So what we can see is there are some fluid levels within the mass along the lateral aspect, and it is causing a large area of post surrounding edema in the flare as well as on the T2. And in the diffusion, we can see that the central solid portion of the mass is showing diffusion restriction. And on the post contrast, if you see, it is showing intense post contrast enhancement. And you can see that the lobulated components are much more apparent in the post contrast sequences. So remember, this is a very characteristic appearance where you have this lobulated mass which is showing intense post contrast enhancement and a very heterogeneous appearance on the T2 weighted images. This is very characteristic for a choroid plexus tumor, and that one actually turned out to be a choroid plexus carcinoma. Many a times it is very difficult to differentiate between the two entities, choroid plexus papilloma versus carcinoma, and it is only proven by histopathology, but gross invasion into the brain parenchyma is one way to be confident about it preoperatively. Right. Let's go on to the pineal region tumors. Pineal region tumors can be either a germ cell tumor or it can be a primary parenchymal pineal tumor. Or out of these, it can be a pineoblastoma, it can be a PPTID or a pineal parenchymal tumor of intermediate differentiation, and finally it could be a pineocytoma. In the pineal region tumors, remember they are typically in a slightly older child. We have some certain serum markers such as alpha fetoprotein which helps us diagnose germ cell tumors here. Blastomas are WHO grade 4 undifferentiated tumors, and it's very important that we screen the spine in such patients to look for CSF dissemination. The two patterns of calcification described here are the exploding versus the engulfing pattern of calcification. So we typically have the blastomas which show the exploding pattern and the germ cell tumors which have an engulfing pattern of calcifications. And many a time whenever we have a pineal region mass, it is very important that we check the supracellular region and also the eyes for retinoblastomas. So let's have a look at this particular case. So we can see here that there is a mass which is arising in the pineal region. It is predominantly cystic. We can see a rind of tissue along the posterior and the anterior aspect of the tumor, and the rind of tumor is showing some degree of diffusion restriction as we can see in the ADC, and is showing one tiny dot of calcification along the anterior aspect, not really easy to characterize there. And if you see in the post contrast, there is some homogeneous post contrast enhancement along the margins of the tumor. So basically we have a cystic tumor with a solid component along the periphery, and this turned out to be a germinoma. Right, let's moving on to the last group of tumors that we have for today is a typical suprasellar mass which we see in the child is a craniopharyngioma. It's a WHO grade 1 tumor. Two different types, as we all know, adamantinomatous and papillary types. Again, two different mutations. I will not bore you with the names of those. The typical histopathology of this is a motor oil appearance of the fluid, and they tend to calcify in 90% of the patients. And remember, if it is an intracellular tumor, a differential for this would be a Rathke cleft cyst. So let's have a look at this particular case. These are the pre-contrast sagittal CT images. We can see that there is a large cellular supracellular mass lesion, and it is causing expansion of the cella. And in the post-contrast CT, we can see that the solid component, the mass, is showing heterogeneous post-contrast enhancement, and the cystic part of the tumor is seen superiorly. No real calcifications were appreciated in the mass, and you can see these are the MRI images of the same. Again, we can see the solid component of the mass here, and we can see along the left lateral aspect, we can see some enhancing portions. So whenever we have a solid cystic mass in the suprasellar region, which is showing some degree of calcifications, and we have enhancing components, craniopharyngioma would be the first differential. Some rarer possibilities would be germ cell tumor. So germ cell tumor typically tends to have much more of enhancement, and we would have a much more amount of solid component in the tumor. Right. So till now we have seen multiple different types of tumors. We have seen some few rare cases as well. Now the next 3 or 4 cases which I'm going to show you are quite different, and some of them are based on pattern recognition, and some of them are quite rare. Just to show you a couple of interesting cases. Right. So this is basically a child who came with complaints of chronic headache. I apologize in advance for the quality of images here. This is the first scan the child had, and it was basically reported as normal except for some prominence of the ventricles here. So no lesion was identified at that point. And this is an oncology talk, so definitely we are going to have some lesions at some point, isn't it? This child was treated as idiopathic intracranial hypertension because of the chronic headaches. He was even shunted. So you can see here, these are the post shunt images which was taken 1 year down the line. We can see that if you look very carefully, we can see these tiny lesions which are here along the left lateral cerebellar hemisphere, and also along the superior aspect of the vermis of the cerebellum, and also in the left middle cerebellar peduncle. So they were not really enhancing at that point, and we were not really sure what was going on, and they were given as non-specific changes. This was the next MRI which was taken 1 year down the line. He was lost to follow-up actually, and after 1 year, this is how it looks like. So we can see the tumor has exploded. We can see that there is a diffuse involvement of the leptomeninges all along the margins of the ventricle. We can see that there are these lesions which appear quite heterogeneous in T2, but in the flare we can see that they are basically suppressed almost near completely in flare. And if you look at the post-contrast sequences, there is no real post-contrast enhancement except for the margin of these cysts, no diffusion restriction. And in the spine, we can see that it's basically coating the leptomeningeal surface both anteriorly and posteriorly. So we have a diffuse disease which has grown over time and basically along the leptomeningeal surface without any post-contrast enhancement and with these characteristic subpile cysts. So this is a very typical appearance for a diffuse leptomeningeal glioneuronal tumor, and this case illustrates the point that we should always follow up children for idiopathic intracranial hypertension who are being treated without a diagnosis. So many a time that can change, and 2 years down the line we may see new lesions popping up. So it's important that we follow them up over time. So this is a newly described entity which is there in the WHO 2016 and 2021 classification, and the characteristic feature of this is basically the subpile cyst which we see coating the surface of the leptomeninges, and it can have nodular post-contrast enhancement as well. It's not necessary that, like in our case, it will not enhance. So some of them do enhance. Some of them we see an article in AJNR which shows a diffuse enhancement of all the lesions involving the leptomeningeal surface. The differential in our case would definitely be infective etiology, because if it was neurocystic sarcosis or tuberculosis, we would similarly see these cystic lesions, and a few of those might enhance as well. So that needs to be kept in the differential. NCC typically would be having cysts at varying stages of evolution. You also see these colex. If you do a cyst or a heavily T2-weighted sequence, you would see that as well. So that becomes important in the differential. So let's have a look at this case. So this was again a child who came with episodes of raised intracranial pressure. You can see that there is a midline mass here which is very homogeneous on T2, and it is again showing this mismatch in flare, and which is having a rim of flare hyperintensity. It is causing hydrocephalus with periventricular edema, and on diffusion there is no diffusion restriction at all, and on the SWI there are no foci of blooming within the mass. What is interesting here is the intense post-contrast enhancement of the mass. So this is predominantly a suprasellar mass, as you can see here. you can see the shape of the mass as well. It's quite pliable, and there is a component which is extending along the prepontine cistern inferiorly. And if you see the pre and the post contrast images, it is showing intense homogeneous post contrast enhancement. So this turned out to be a pilocytic astrocytoma. Just to tell you that intense post contrast enhancement does not necessarily mean a high grade tumor in the pediatric population. That is very important to remember. So we can have tumors which intensely enhance, which are low grade, and at the same time we can have tumors which restrict and not enhance, and they are high grade. So that is very important that you remember this principle in pediatric. Right, so this is the last case we will see for today. We can see this again, a very large mass which is epicentered in the left basal ganglia and the left temporal lobe. It has an oblong shape, and you can see this heterogeneous large components within the mass. You can see that the mass shows some area of diffusion restriction within, especially the solid components along the lateral aspect. There are areas of calcification within the mass more on the anterior aspect. And if you look at the post-contrast images, we can see that this is the pre and this is the post. We can see that the rim of the mass is enhancing. So any ideas about the diagnosis here? So it's very important in the pediatric age group and in neurology, radiology especially, that we check all the sequences we have available with us. So if you just look at the first and the second sequence on the bottom and the first and the second sequence here on the left, the diagnosis can easily be made. We don't even have to look at all the other sequences. So if you look at the bottom sequence, we can see this is not a fat suppressed sequence. It's just a T1 with T1 plain T1 image axial, and we can see that these areas are quite hyperintense in T1. And if you see in the axial T2 fat suppressed sequence which is on top, we can see that all those areas have become suppressed. So that becomes, the diagnosis is clear cut here. It becomes intracranial teratoma, and intracranial teratomas, one of the complications is a rupture of the teratoma and aseptic meningitis. So it's important to remember to look at all the sequences we have available with us before reporting the scan. Right. Just to summarize what we have learned in today's class about pediatric brain tumors, we started off with medulloblastoma, which shows a high degree of cellularity. So it's very important that we look for diffusion restriction in those tumors. ATRT, as I told you before, is very heterogeneous and it tends to be lateral. And any child less than 1 year of age in the infantile population, ATRT would be the first diagnosis. Among the supratentorial tumors, if it is an embryonal tumor, it tends to be very large and hemispheric, and it's usually in a younger child. Whereas if it's in an older child, we would think of a non-midline diffuse high-grade glioma. The age group is what basically differentiates between the two. If it is a pilocytic astrocytoma, we would think of a cyst with a mural nodule configuration in the posterior fossa. A diffuse midline glioma is very characteristic. It happens in the midline, though not always in the pons. Encasement or engulfment of the basilar artery is a very critical feature there, which would help us make the diagnosis. A supratentorial ependymoma, on the other hand, as I told you before, calcifications are a very important feature, and they have this periwinkle sign or periwinkle calcifications which help us make the diagnosis. Gangliogliomas in the supratentorial parenchyma, it has a cyst with a mural nodule configuration and it will intensely enhance. DNETs typically will be bubbly in appearance and will have a cortical rim side. Choraplexus tumors, we saw, will have a frown-like appearance, intense post-contrast enhancement. They tend to be intraventricular, predominantly in the lateral ventricle, and a pineal region mass usually will have these calcifications, help us distinguish an engulfing and exploding pattern. These are the two articles which I found quite useful for my references. Pediatric brain tumors in the molecular era, an update for the radiologist. It talks a lot about the genes which are involved in the tumor, and the first one actually gives us just a broad classification of pediatric brain tumors in the WHO 2021 classification. These are my references. I would like to thank my alma mater, CMC Vellore, and Aster Radiology, as well as the hospital I'm currently working in, where I'm a fellow, Great Ormond Street Hospital, and Dr. Kish Mankat for providing me the opportunity for this talk. I hope all of you had a great time today, and we covered almost all the pediatric brain tumors which are seen in a day-to-day practice. Thank you very much.